one of the things that Gail and Richard and I came up with, and and frankly, it's not necessarily a new concept, but it may be new to you, and it may be new to some of the people who are watching this, who are even professionals, because it really is kind of another option for patients
end stage
who are end stage, meaning they have a very limited time remaining, that they may be at a point where breathing is very difficult. They may be very anxious. They may be very depressed.
They may be in severe pain.
They may be in incontractable pain, inconsolable in terms of suffering. And so one of the things that I'm very aware of is that the physician's ability for patients who meet that criteria to really be sedated, and to be sedated significantly so that they just sleep.
So option 3 is assisted slumber. They basically do a type of coma, and you just peacefully sleep. And the disease process that you are going to die from is just allowed to progress. It's not something that helps you die. It's just something that puts you at peace so that your body can do what it's trying to do, which is get you off the planet.
The value of doing this is that it would not necessarily be seen as suicide.
No.
In fact, it would be just, in some respects, seen as just good treatment.
It's not even discussed as suicide.
And being in this position where a patient basically says to their doctor, you know what, at the end, I really don't want to be aware. I don't want to be awake.
I just want to go to sleep.
I really just want to be able to sleep. And that there's a point in time where patients want that, and they know that that's going to be done. I've seen it in hospice many times, and the reality is that it's not something that we talk about because it's really individual. And it's something that not everybody wants or needs or even would know to ask for. But somebody who has inconsolable suffering, pain out of control, not being able to breathe, having extreme difficulty in getting their symptoms under control, may be an appropriate person for assisted slumber.
And it would be done in hospice.
And that would be the context. I mean, you would be a hospice patient and basically being managed by a registered nurse.
What is that?
It's an incoming call.
Oh.
I don't know if these are showing up on the screen whenever I'm. They could be. I have no idea. But anyhow, so assisted slumber is basically assisted sleep, being given enough medication so that you, not to push you over the edge, but basically to make it so that you're comfortable, and being extremely comfortable to the point where you may pass during the period of time after you've been placed on that.
Right.
But
again, this is the last few days of a dying patient. This is not something that can be done 3 months in advance. This is cannot be done for the long-term patient, for the ALS, Parkinson's, Huntington's, long-term cancer patient. This is something that's just probably less than a week, Michael.
Perhaps.
Yeah.
And it's not usually something that, like I said, that is offered or suggested, except in those situations where it kind of makes sense.
And usually the nurse that's responsible at that time for your medication would probably signal the doctor that she was going to increase it to that level.
Absolutely, and I think that it's very humane from that standpoint, and it's also something that allows the family and those who have been caring for that person to really honor that person's wishes to not suffer.
Correct. And you can, one of the things that we have done is we have written up your pulsed document to state that you, at the end, you would like option 3.